Tanoy Bose. I'm a consultant rheumatologist and I'm here to discuss how rheumatoid arthritis is diagnosed and is there any specific laboratory test to diagnose it. Diagnosis of rheumatoid arthritis is actually clinical. It is characterized by pain and swelling of small joints of the hands with early morning stiffness that lasts for maybe a couple of months, and there are evident swelling and inflammation of the joints. These patients are unable to eat, they can't eat, they can turn the keys, and clinical diagnosis is very much, we can be very confident about the diagnosis if this kind of symptom is present. Further, presence of rheumatoid factor, which is present in around 70% of the patients who are suffering from rheumatoid arthritis, and a new antibody called anti-CCP antibody. If this is present, then we are almost sure that the patient is suffering from a rheumatoid arthritis. Now, if you want to know more about rheumatoid arthritis, I would like to tell you that perhaps it is the commonest rheumatological complaint in OPD apart from osteoarthritis. This rheumatoid arthritis tends to affect the small joints of all the hands and the toes. Actually, it starts affecting from the toes, and people hardly complain about the toes, but as a doctor we should always look for any changes such as swelling or pain in the toes. We squeeze the hand like this to find out whether they have any pain or not. Sometimes patients who are already on painkillers, they don't come with evident swelling or inflammation. So in that case the diagnosis is a little bit difficult. So we need a proper history in those patients. Further, if we go for an ESR and CRP tests in the blood, these are actually acute phase reactants. They are high whenever there is any inflammation in the body. So if ESR and CRP is also high and we get the positive rheumatoid factor and anti-CCP antibody, which may be negative in some also, I must mention this, even then rheumatoid arthritis is possible and we treat these patients. Now the treatment is basically with initially tapering dose of corticosteroids, which are started in a moderately low dose, and it's tapered over 2 to 2.5 months. And the mainstay treatment for rheumatoid arthritis is methotrexate, which is given at a dose of maximum dose of 25 mg per week. Added to that, we get hydroxychloroquine sulfate, sulfasalazine, leflunomide. We don't have any other medicines apart from these in an oral format. We have to take care of the side effects of these medicines, which include oral ulcers, lack of appetite, flatulence, gastritis, and sometimes anorexia, vomiting, especially with methotrexate. They also have side effects like affection of the kidneys, liver, lungs, and we doctors or the rheumatologists keep this patient in a 3-monthly visit so that we can find out whether there is any damage to any of these organs or not. Beyond this, if the patient fails to respond to the maximum doses of all these medicines, we prefer to use biologics. These are high molecular weight chemicals who actually target the inflammatory mediators in the blood. They block the inflammatory mediators and patient get a very good relief, but mind it is not a curative treatment. The patient who are on biologics may need biologics again, maybe lifetime for some, but they can achieve remission. The target of treatment is the patient should not have a single swollen joint, there should be not a tender joint, the ESR should be less than 10 and the CRP should be less than 1. Continuous physiotherapy of small joints of the hands when there is no pain is a mandatory thing in management of rheumatoid arthritis. I would wish best of luck to all the patients and all the viewers who wish to know about rheumatoid arthritis to dissipate this particular message among their kith and kins so that people get well oriented about this disease, and it is best results are obtained when you hit hard when the disease is young. Thank you.